This meeting is being recorded. Welcome. This is Caradina Sale from the Community Technical Assistance Center and Managed Care Technical Assistance Center of New York State. Today, our webinar is called Interpersonal Approaches to Treating Depression in Adolescents and Adults. Our presenter today is my brilliant colleague, Mary Acri, and I'm so happy that you all get to learn from her today. She's a mental health services researcher with a background in clinical social work whose research interests center on developing and testing interventions to enhance the detection and treatment of mental health problems among children and their caregivers. She works here at the McSilver Institute for Poverty Policy and Research. She's also a research assistant professor at New York University of School of Medicine's Department of Child and Adolescent Psychiatry, as well as an adjunct faculty member at the Silver School of Social Work. Before we get started, I want to take a moment to orient everyone to our WebEx system so you know how to participate in today's event. Please note that you're all placed on mute, but we are going to ask anyone to participate in our active case study at the end of today's webinar, really applying some of the work that Dr. Acri is going to talk about. And so in order to do that, if you'd like to participate and think about someone that you work with depression and applying some of these interpersonal approaches, we're going to ask that you call in, and Brianna has chatted in the call-in number, and you need to enter your attendee ID in order to participate in that. So we will ask if anybody would like to participate at the end, and towards the end, and we'll ask you to raise your hand, and then we will select someone to do that, if that's okay. And if we have time, maybe we could do 2 people. Anyhow, but for now, you're all placed on mute, and then we will attend to the case study towards the end. If you come across any technical issues, however, please chat to the host, who's Brianna. Thank you, Brianna, who will be able to assist you. You also have the opportunity to submit questions, so please, if you want to chat in questions during the presentation, I will be collecting those, or we will also have time for a Q&A at the end. The chat box feature is located on the right-hand side of your screen. If it's not visible, there's a dialog bubble on the top right toolbar, and it should appear. In order to ensure that we are able to answer as many questions as time permits, as I said earlier, I'd love for you to send them in along the way. And we are just very excited and grateful to have Dr. Mary Acri with us today. And once again, thank you for joining us. I'm going to pass it over to her.
Hi, thank you so much for the introduction, Kara. So today I'm going to talk about interpersonal approaches to treating depression in adolescents and adults, and give you an overview of depression, its prevalence, some of the factors that increase the risk for depression amongst adolescents and adults, and then move into different ways that you can assess for depression and its relationship to interpersonal factors deriving from theory, as well as an evidence-based intervention, which we'll talk about at the end, called interpersonal psychotherapy. So, and as Kara had stated before, that we'll also review a case example from the audience. So in terms of depression, is depression a common diagnosis that you treat or provide services for? We do know that depression is quite common across the lifespan and has a twofold prevalence among certain groups that we'll get to in a minute, such as women. But it is likely that folks who are mental health professionals have many clients on their caseload that have either depression as a primary or a secondary problem. We also know, with respect to depression, that there are many treatments out there. There's pharmacology, there's psychotherapy, and then there's different forms of psychotherapy. So you may be doing very different things in terms of your treatment with adolescents. It may or may not involve the family, or you may be working individually with that adolescent. The same thing with adults. So adults, there are many treatments out there that are used both for adolescents and adults, depending on severity and setting. So in terms of the prevalence of depression, it's a common mood disorder both within the U.S. as well as worldwide. The World Health Organization states that depression is the second leading cause of disability, and by 2020 it may become the first. And epidemiological studies have shown a prevalence rate amongst the general population. So these are non-clinical samples. These are folks who are surveyed, usually in their household, who may not be in treatment, but that approximately 4 to 5% of adolescents have a depressive disorder annually, and approximately 16% of adults will have a depressive disorder at some point during their lifetime. But we do know, as I alluded to previously, that there are certain groups who are at increased risk for depression. So women, from the point of early adolescence all the way through the lifespan until the elder years, have a twofold incidence of depression compared to men, as well as persons living in poverty. A recent review of multiple studies found that approximately 1 in 4 individuals who lives in poverty experiences a depressive disorder. And that doesn't include all the individuals who may be symptomatic but not diagnosed as depressed, or who may be not on the radar for whatever reason. So it's likely that those rates are much higher. In terms of burden, depression exacts a huge burden to the caregiver or the adult, the family, and then societally. So we know that when depression remains untreated, it's associated with impairments in multiple areas of functioning. Among adolescents, you will typically see impairments in academic functioning, with their relationships with their peers and family members. For adults, you will see economic and occupational impairment, missed work days, lower productivity, and so forth. You also see a high degree of comorbid health and mental health disorders that accompany depression. So we know diabetes, cardiac issues are highly comorbid with depression, as well as other mood disorders, anxiety disorders, and substance use. And that it has depression is associated with premature morbidity and mortality. And in the United States, we've estimated that the annual economic burden of depression is approximately $52 billion. And that's attributed to lost productivity and work days, as well as additional services that we need to scaffold individuals who are experiencing depression. So our understanding of depression and the factors that are associated with developing a depressive disorder range across biological, psychological, and social factors. So we do know that depression has a high genetic component. Studies of twins have shown concordance rates of depression ranging from 31% all the way up to 69%. So that suggests that there is an inherited or a genetic physiological basis for depression. We also know that there are a host of psychological factors that increase risk. That would mean and include the comorbid mental health problems such as anxiety, having a history of past suicide attempts. Having a prior episode of depression is also a risk factor for a subsequent one. And then environmental and social factors, and those include stressful life events and early childhood experiences, trauma, and social isolation. We do also know the literature suggests that among adolescents, the clearest predictors or the strongest predictors for a depressive disorder is having a family history. So part of that is that genetic component, and exposure to stress. So there are various theories behind why individuals, the interpersonal role in depression, and I'll go through these pretty briefly. The first is object relations, which has historically shaped mental health services and how we conceptualize functioning interpersonally. And it's one of the 4 schools of psychoanalytic theory. So the origins of this include Mahler and Winnicott and those early object relationists who really saw depression as emanating from disturbed object relations during childhood that then influenced the future difficulty in developing positive relationships. So, you know, very much their past and your early childhood relationships, usually with the parents, then set in stone something that in adulthood or later on affected how folks formed relationships with others, and in the case of having dysfunctional relationships leading to depression. There's also the interactional theory, which is that basically through your interactions with others, so the quality of your social relationships and the people in your life, it could also influence depression or lead to a depressive episode. And interpersonal stress. So this, one of the qualities of some individuals who experience depression may be to ask for excessive reassurance, and generate, as a result of that, they generate negative life events that also, and social interactions, which also lead to depression. And why these theories are important is because they form the foundation for many of the treatments that take an interpersonal focus. So we'll see when we discuss interpersonal psychotherapy that very much derives from object relations theory in terms of your early child relationships influencing your current ones, and in turn that portends upon your emotional health. Okay. In terms of assessment, there's many ways in which you can assess for the quality and the quantity of interpersonal relationships, and that becomes a point in which you can develop an intervention or a care plan. And one of them is the biopsychosocial spiritual history. And this has had a long history in social work as well as other mental health disciplines, where we're really assessing what is going on in the individual biologically, psychologically, and socially. And so from an interpersonal framework, we look at the quality and the quantity of the relationships with other individuals, in addition to these other factors, when we form a conceptualization of what we believe is responsible for why that individual is experiencing depression. And that relationship bubble also includes family, extended family, friends, anyone with whom the person has an interpersonal relationship with, or the lack thereof. So again, one of the thoughts is that depression is not helped and hindered by social isolation. And so if you're lacking or you have discordant relationships with the key people in your life, you would pick that up in this form of an assessment. A genogram is another way you can assess relationships. And again, all of these assessments, they're not perfect, but they do give you insight into, especially with the genogram, who is in that person's family, immediate, and then going up 2 generations or up and down, one generation up, 1 generation down. You can look at deaths, divorce. There's the dotted lines that indicate stressful relationships. So this is a good way to identify, and if you look at the genogram, Betty, who's 24, she's married, she has a child who's 6. It's a good way to get a picture as to who's in Betty's life. And then through the use of dotted lines or stronger lines, you can detect if there's conflict or there's any kind of interpersonal issue going on. The eco map is another one, and there's a lot going on in this picture, but it's more comprehensive than the biopsychosocial spiritual perspective and the genogram because it's wholly interpersonal. So the family unit is depicted in the center, and then all of those domains in which the individual or family is connected to circle that family unit. And again, the use of lines tells you about the strength of the relationship, the direction of energy. So if we look in the lower right-hand corner to the male child, there's a strong amount of energy going towards his friends, and it's a very strong relationship, and then it's bidirectional. You may see fractured relationships, and that's, or discordant, and that's indicated by the dotted line. And if you look at just to the left, the counselor, there seems a lot of energy from the counselor to the male child, but not the reverse. So this gives you a really great picture of what are all the domains that are going on that are interpersonal in nature, and again, where there might be deficits or areas in which you can shore up as a point of intervention. And the social network map is somewhat similar to that, but it deals more so of who does that person conceptualize as within their intimate circle, do they have close family and friends, and then distant, and then gradating outward towards the family, the community, work and school, and so forth. So these are all pictorial representations that you can utilize to get a sense as to the quality and quantity of the individual's interpersonal relationships. You can also use screening and assessment tools, and these are usually specific and vary based upon the type of relationship. So, for example, to skip down to number 2, the Dyadic trust scale, that really looks at the amount of trust or the relationship between two people in a romantic relationship. Whereas the brief impairment scale, which is used for adolescents, assesses for functioning overall, but it also looks at interpersonal relationships. So you can use a combination of pictorial representations like the eco map and to home in really specifically on one type of interpersonal relationship if that's what you would be guiding your treatment plan towards through one of these measures. So there are strategies that a therapist from an interpersonal perspective would utilize in general, so across therapeutic approaches. And really the strongest one is to help the individual understand the connection between how they are feeling and why. So what is really going on in that interpersonal relationship? And what that would entail is you would do a lot of digging in terms of what is the interaction like, how is your client relating to that individual, how are they relating to your client, and to really be attuned to any breakdown or areas that you can enhance or strengthen. So there may be communication patterns that are not as strong as we'd like them to be, or anger issues or anger management skills that you might work with your client on, depending on the nature of that relationship. The other, and this again derives from object relations theory, is to look at the quality of the individual's prior relationships and how those relationships influence their current ones. So are there any themes or any kind of ways in which that individual is currently dealing with others that emanate from the past in their earlier relationship? And does that in turn affect their emotions? So for example, you may have a client come in and say, you know, I've been feeling like so-and-so ignores me, or he doesn't pay enough attention to me, and through discussion with you, it comes out that that's very much how they felt in their first marriage or when they were growing up with their parents. And looking at the connection between that and then going further and trying to correct through skill enhancement and education. So it may, again, be communication skills or problem-solving skills that you can bolster within the client so that they break that relationship, so to speak, between the earlier influences and the current one, and they learn to interact more adaptively. When working with couples and families, and this is key to couples therapy and many types of family therapy, is really looking at that family as the unit in which you are assessing and correcting communication patterns or unrealistic expectations about how these family members interact with each other. And based upon that, assessment, you would then bring in interventions that would hopefully strengthen that family unit, and that might include communication skills, education. I've had some experience as a behavior parent therapist. Part of what we've worked with families on is really understanding what is developmentally appropriate for a child in terms of their behavior at a certain age, and that can be therapeutic in and of itself, so correcting unrealistic expectations and ultimately changing patterns of interaction. And critically, using modeling and role-playing to correct and to develop new ways of interaction. That is a very powerful therapeutic technique that cuts across many approaches that can be very helpful in helping the person react differently and act differently in interpersonal relationships. So now I'd like to talk about a specific form of interpersonal therapy, and it's called IPT, or Interpersonal Psychotherapy. It was developed in the 1970s by Clareman and Weissman and others as a way to treat depression. It's a fairly brief treatment in that it ranges from 6 to 20 sessions. They've actually developed shorter treatments, a 3-session IPT. And it has been shown in numerous research trials to be effective for adolescents and adults with depression, as well as expanded for individuals, couples, and groups. And key to this therapy, and we'll get into this in a minute, is that the stress diathesis model, which we'll talk about, that incorporates a biological perspective as to why the individual is experiencing depression, as well as an interpersonal factor and how that can be the stressor in the individual's life that can lead to a depressive episode. So IBT, as I said, is a stress diathesis model, and we know that psychosocial stressors from one of 4 problem areas, which we'll also talk about, can lead the person to become distressed. And also, in addition to that, how that person addresses and deals with that stressor can also influence how they react to it. And the real goal of IPT is symptom reduction, so to improve functioning and enhance social support. And that's the goal, remittance of depressive symptoms. So in IPT, we talk about the interpersonal triad, and how it's conceptualized is that you have some biologic basis for depression. So depression is treated from a disease model perspective, and your interpersonal episode or distress leads to psychological symptoms. So the individual's capacity to deal with or manage that interpersonal issue is predicated on how they, if they have this biological vulnerability, as well as strength. So again, their temperament, their attachment style, their coping skills, and that may modulate or increase the crisis. Now we look at significant relationships and social support as buffers or potential areas of vulnerability that can either help modulate or, again, worsen the crisis. So the problem areas that IPT deals with are, there's 4 of them. The first is grief, and that's actual death or loss. So that's someone, mourning that has not remitted. The second is interpersonal disputes, so that might be disputes within families or within a relationship or someone that they're close with. Role transitions, such as a divorce, a new job, a diagnosis of a health condition. And the role transition doesn't need to be inherently problematic or a crisis. It could be, becoming a grandparent. It could be something that is just different for that individual that may be problematic in terms of their response. And finally, interpersonal sensitivity, and this used to be called interpersonal deficits, difficulty forming and maintaining relationships. And usually in IPT, you work on one problem area at a time, although the individual may have multiple problem areas. So the structure for IPT is similar for adults and adolescents with some differences, but among adults, you would start with an assessment. So you would do a clinical interview and determine the appropriateness of IPT for the individual. So that clinical interview, why are you here? What are you presenting with? Give me your background. And that you would collect a biopsychosocial, spiritual, cultural assessment where you would want to know, have they had a physical recently? Do they have any medical issues that could be contributing? What is their psychological history? What's going on in their environment? In the initial sessions of IPT, you would create an interpersonal inventory. So who is in that individual's life? What is the quality of the relationship? Are there any deficits in terms of lack of social support or relationships? And then you would contract for a number of sessions. So in the initial sessions, you would also create a hypothesis or a formulation as to why you believe that individual is experiencing depression. And it may be, you know, so you were getting divorced and that has been very stressful for you, and you've had a few depressive episodes in the past, and so your symptoms of depression, while it is biologically based, may have been influenced by or may have been set off by this change in your marital status. You would then contract again for a number of sessions, and during those middle sessions, you would address the relevant problem area. So you would dig in and figure out what is really going on interpersonally, what are some of the strategies you can use to bolster that individual's supports, as well as their own strengths. And then it is relatively short term, so the next step would be to terminate. However, maintenance is built in. It's expected that you would come back. So with this, there's education about how do you know if you need to come back into treatment, but in addition to that, let's set booster sessions, have you come back in a couple of weeks and see how you're doing. So the adage is that, you know, coming back once in a while isn't going to hurt anyone. It's actually good for your emotional health. Okay. And the techniques that you would use are pretty much generalized, that you would use this when you're working with clients with other difficulties. So exploration of what is the issue or what's really going on. Clarification, to encourage the individual to associate emotions with what's going on in their life. So how to express emotions appropriately in reaction to whatever interpersonal issue is going on. To really dig in terms of the individual's communication and the quality of their communication, and how we can adjust that so it's more adaptive and learning new ways. Role play and problem solving. And critically, this all hinges on the therapeutic relationship. So having a genuine, authentic relationship with the therapist is the vehicle through which all the other work can be done. So IPT for adolescents, and it's been studied mostly for adolescents between 12 and 18 years of age, also spans from up to 16 weeks, and the goal is also remittance of depression. And what you're really targeting here is, again, strengthening communication and problem-solving skills. In contrast to adult IPT, though, the adolescent IPT involves families. So the caregivers receive psychoeducation about depression, about its biological basis, and how they can interact differently through strengthening the family's communication and problem-solving skills, as well as helping the child to develop their own skills and practicing that between sessions. So in the initial phase for IPT, it's provision of psychoeducation about depression and assigning the sick role. And that's true for adults as well, that right now you're going through something, you're depressed, and that's not your fault. But while we work on this, we're really going to treat you as if you're experiencing something that is hard for you. So it's understandable that you may not want to, say, go out with your friends every night or do the things that you normally do because you've got an illness. You would also conduct an interpersonal inventory and, again, formulating the problem area from those one of 4 areas. In the middle phase, that's where the work is done. So again, similar to adults, you would work on communication and problem solving. You would do a communication analysis. You would provide skill enhancement if there were issues in those areas. And you would do a lot of role playing and homework assignments with the caregivers. And then the termination phase is such as with the adults. You would review your work together and the feelings about ending, but also put in a plan of how can you help identify if you are potentially relapsing, and you know what, let's meet in a couple of weeks and we'll see how you're doing and check in, okay? So part of understanding this is how you would apply these approaches to an adolescent or adult with depression, and what strategies would you use. And keeping in mind that these strategies aren't completely divergent from what you would do working with other individuals with other difficulties. However, the solutions that you come up with or the interventions always have an interpersonal focus. So if you were working with someone who was isolated, one of your solutions would be to decrease their isolation through social activity. So there's, it's similar to cognitive therapy and behavior therapy in that we're identifying what the issue is, but the set of techniques in interpersonal therapy always has a focus on improving the quality and strengthening relationships with others. So that may mean developing hobbies. It may mean going out and addressing an issue with your boss in a respectful way, but there's always an interpersonal focus to it. So when you're thinking about your own clients, it may be helpful for you to conceptualize it from an interpersonal framework.
Yeah, that's great. Thank you so much, Dr. Acri. This is, I think, really helpful for so many of our providers around the state. I'm just going to chime in here to see if anybody would like to share a client or participant in care that you're working with who has depression and using some of these approaches to help them with their depression. So it looks like Sarah C. would like to participate. Brianna, can we, or maybe that was Sarah, would you like to participate? Please raise your hand. There's a hand icon. If you look under attendees, you'll see a little hand icon. If you'd like to participate, you can raise your hand and we will unmute you to hear a case from you. So it looked like Sarah had raised her hand, but maybe that was an accident. So we'll just wait a few seconds, see. Okay, Linda, it looks like Linda would like to participate. Oh, Sarah doesn't have a microphone. Okay. You can call in, Sarah, and use your attendee ID, and we can unmute you. If you have a phone nearby, you can call in. Otherwise, we could go to Linda. We might have time for a few, but we'll have to see. Linda, Brianna, can we unmute Linda? Linda Kolb-Schweitzer.
Hi, Kara. Linda has to connect her audio conference call to her username, and I'm not able to identify her call-in user at this time, unfortunately.
Okay. So I'm putting it in the chat. So if you would like to do this, thank you for your patience, everyone. If you would like to participate, you can call in. I'm chatting in a call-in number and the access code. How do they find their attendee ID, Brianna? Because that's how they have to be identified.
Yep, they can go to the Quick Start tab or the Event Info tab.
Event Info.
But Linda is willing to chat with us in the chat box as well.
Okay. Oh, mine just shut down. Okay, Linda, do you want to just chat in with us and we can get a sense of what's going on? Okay, Linda, if you want to just share a little bit in the chat box and I can read it to everyone. If you want to share some information about the person you're working with, and then we can, Dr. Acri can talk with you about some of the strategies and techniques you could use. How does that sound? And then Sarah, you could also do the same so that we could attend to that afterwards, because it doesn't seem like I'm muting anyone is going to really work out. So Linda said she could not complete her freshman year in college and did not complete finals. She was socially withdrawn and is struggling now at home.
So I'm just trying to get a sense. So struggling in what way at home? She has a history of social struggles, relationships were superficial. Okay. And she's 18, 19? Friends and social connections. Yeah. So the work that you would want, oh, there's a couple going on.
Let me help. I'm getting back on. Okay. So we have a couple people. This is great. We love this. A lot of you are chatting in. We're going to focus on Linda first. So she is working with an 18-year-old female, and it sounds like she, if we want to just scroll up so we can get. Okay, so she could not complete her freshman year in college and did not complete finals. She was socially withdrawn and is struggling now at home. She has a history of social struggles, relationships were superficial.
Yeah, so part of the work that you would do from an interpersonal perspective is to really trace back the quality of her relationships from that with her parents and any of her immediate family. And again, from an object theory perspective, the premise would be that something in those original relationships or those early relationships is carrying over to the current ones. And so social, it's kind of hard to pinpoint without doing a huge interpersonal inventory. But some of the things you would want to know about is, did she, what was the quality of her relationship with one or both parents? Who was in the home? Whom else did she consider having a relationship with growing up? What was the quality of her parents' relationship and the people around her? So you would really want to dig into those early interpersonal relationships. And then what is going on now? So when she says, she has a history of social struggles, what does that really mean? Does that mean in relationships with someone she wants to form a partner with? Is it that she, just trying to delve in as to what really is the issue and bringing in examples. So one of the things that can really be helpful is if she actively brings in, history of a relationship with, say, a friend that exemplifies that it's a superficial relationship. So what does that really mean? And then gauging what's really going on with this individual. Is it a communication breakdown? Is it that she's afraid to have a deeper relationship with the other person, and what's driving that fear? And then you would build your intervention based upon that. So let's say that she has a hard time meeting people. Then this is why the internet is just really exciting at this point. You could work with maybe a goal being to join a meetup on an area of interest or an online chat group, and then work from there. So that would also include some behavioral principles of shaping. So maybe the ultimate goal is to diversify and to increase the individual's friends and quality of their relationship. And so starting small with maybe going on a meetup, which is actually a huge thing, and working towards that, getting success, and then moving to the next step to strengthen her connections. And if there's any kind of work that she needs to do in terms of communication, in terms of problem solving, those are also ways in which you can actively bring in strategies to bolster their skills in those areas.
And do you have, so it sounds like Linda's chatting in some more information, saying that one of the challenges is her client does not initiate any kind of communication with others, so she really keeps her feelings to herself, and she also lacks some confidence. So is there any kind of strategy regarding interpersonal approaches that you would recommend? Or do you have anything that you think you would do differently, Linda, in regards to working with her now that you've heard Dr. Acree's strategies and some ideas around using interpersonal approaches?
I also see that you wrote here that the parents are confused and somewhat frustrated with her, and that's a perfect opportunity. I mean, if she's 18 or 19, she's still an adolescent. And to work with those parents in terms of education. From IPT's framework, if she's experiencing depression, that is something that is not in her control right now. And so really to, sort of be gentle with that and to understand the role of depression and how it very much affects the quality of your interpersonal relationships. So, not initiating communication is, there may be an anxiety component to that you would assess for, and lacking some confidence. But also, the power of role play and modeling can't be underestimated. It actually changes your brain functioning. And so giving the confidence, she can gain confidence through role playing with you and modeling different scenarios and then trying those out.
Yeah. That's what she said. She did a little bit of role play.
So
great. That's fantastic, Linda, that you role played some ways to communicate and that you really, it sounds like you agree that she also has some anxiety going on.
Yeah.
And maybe some social anxiety. That's a huge change. A role transition. It reminds me, as you mentioned.
Yeah. So I would want to know a little bit more about what was going on with college, and was it an academic reason? Was, she is trusting you with help, which is amazing. So, and that's the beauty of the work that you're doing with her, is that you have an interpersonal relationship, and that through you, she is learning how to trust and to enhance your communication optimally. So you're modeling that for her just through your therapeutic work, which is amazing. That's great.
Yeah, absolutely. Okay, great. So I'm wondering, it looks like a lot of chat that's coming in at this point are really around questions for Dr. Acri, so I think we're going to move into the Q&A. I hope that was helpful, Linda. If it wasn't, please chat in any kind of remaining questions you have or anything else you think you may do differently. That would be helpful for us to know. But in the meantime, we have some questions, so we're going to move it into Q&A. And Sarah did have a question. Oh, Linda said that was helpful. Thank you. Thank you.
Great.
That's great. So Sarah had a question that's slightly different. She asked, how can a worker help others see that the person is more than the diagnosis? So how can a provider help others? And when you say others, do you mean the client or participant in care or your coworkers? Oh, court system. So how can we help the court system help people see more, that they're more than just a diagnosis?
Yeah, I think that cuts across many sectors. And the answer, I think primarily, at the end of the day, there are folks who will pathologize and they'll just see people based upon their diagnostic, their diagnoses, but through education. And psychoeducation is actually it's used for parents of children with mental health problems. It's used for adults with mental health problems. It is actually a very therapeutic approach in depression, but also to help family members and other systems understand that there's, especially with depression, there's a huge biological component to it. You also confront major stigma, and how do you experience depression is predicated on your own views. So there may be stigma that's driving how other systems view that individual. I guess it would depend how much control you had over those other systems or settings.
So I think Sarah wanted to clarify a little bit that maybe it's actually how can the workers help clients show the court system is more than their diagnoses.
Yeah, I guess I would need to know a little bit about the capacity, like what is the court system's involvement in that individual with that client.
Yeah. I don't know if we're getting to your question, Sarah.
Yeah.
Feel free to chat in any other details. We're going to move on, though. We did get an interesting question, and then we can come back to you. So one question that we have is, how does the current political climate affect the prevalence of depression?
So from an interpersonal perspective, it would, I would surmise that if there was a, depending on your view of the political climate, as well as what's going on socially, we've had 2 recent suicides of 2 very famous individuals who connected with a lot of folks over different areas, that it absolutely influences how some folks experience, their own emotional health. I think the suicide issue is actually one of the positives that's come out of it is it's opened up a dialogue. However, it's absolutely appropriate that people would feel concerned over political issues, social issues that are going on. And so really normalizing that for your client and saying absolutely, it's actually quite healthy that you would be impacted. And so how can we help to have that not interfere with your life, but maybe that is then an avenue for change. What can you do to protect for self-care, but also to hopefully combat that?
Mm-hmm. Great, thank you. If you have any other questions, please chat in. I'm going to go back to Sarah for a second. What she said is the short version is that mom has been threatened with her parental rights being terminated due to her own mental health. So it sounds like mom may be suffering with depression. Mom is actively and appropriately engaged in treatment.
So that's where, as caseworkers and as the advocates for that individual, peer family advocates in the, I'm assuming it's the child welfare system, need to advocate for that individual, and that receiving treatment is an absolutely appropriate and healthy response. And it is not uncommon for people to fear getting therapy because they feel like they'll lose custody of their children. So I do think that part of that is an education piece on the folks who are working with that caregiver in service of reunifying or maintaining custody.
Mm-hmm. Great. We have a question here. How is suicidal ideation addressed in IPT?
Yeah, I think this also goes along with, I think there was a question how to recognize the signs of
depression, and how can we recognize the signs of depression? Great.
So depression, there's different types of depressive disorders. There's dysthymia, which if you look at the Diagnostic and Statistical Manual, differentiates between different types of depression, and you have to have certain symptoms for a specific period of time. The prevailing symptom is a sad mood. There are things about the individual. They may feel hopeless. They may express hopelessness. They may express appetite changes, sleep disturbances, either sleeping too much or not enough, anergia, which is a lack of energy. They may be missing work days. They may be drinking in excess. So there are a host of symptoms that the DSM, the Diagnostic and Statistical Manual, picks up on, but also, asking about their eating habits, their sleeping habits. Have they become socially withdrawn? That's usually a big indicator. The other issue is in terms of suicidal ideation. As a mental health therapist, you're assessing for risk at that point. So you would do a comprehensive suicide assessment. Have you had thoughts of harming yourself? What are those thoughts? What are some of those thoughts? Do you have a plan? Do you have any weapons in the home? Do you have a means? And it may very well mean that that person is evaluated at a psychiatric ER if they are displaying ideation, intent, and or plan. So you would make sure, IPT doesn't, you would still work with the individual, but you would want to manage their suicidality first.
Mm-hmm. And to create a safety plan.
Right.
Mm-hmm. would be really important. We have a question here that says, I'm working with a 15-year-old transgender female to male youth who is taking testosterone and some antipsychotic medication. He also self-medicates with marijuana, has an emerging eating disorder, and is very angry towards his parents. Sometimes expresses homicidal ideation towards his older siblings. How do I work with a client to help him strengthen his interpersonal relations?
Yeah, so there's a lot going on with that family system. I think that a family therapy approach might be the way to go. Interacting how family members, you know, first of all, he's going through a role transition from an IPT framework, clearly. And also 25, I believe.
17.
Oh, 17. Wow, okay. That's also a period.
No, 15.
Oh, wow. That's
Sorry.
pretty young.
Yeah, young. Very young.
So, you know, I would encourage a family therapy approach to that. I don't, you know, without knowing more of the history in terms of when this started, the homicidal ideation should be taken very seriously. We are mandated by a duty to warn. And so to really flesh that out and to make sure everyone's aware. But without, you know, some of the things I would want to know is what's going on with that individual now that may be contributing to their mental health distress. You mentioned he's on antipsychotics, you know, what for? But that if the family was able to really work on their patterns of communication and interaction, because it sounds like there's quite a bit of conflict across the board.
I hope that's helpful. It sounds like you all are doing such amazing work, and that this is resonating with you. So thank you for sharing all of your questions and concerns. We have time for one more question.
The rest of the family's not interested. Wow. He was recently expelled from school. It seems like he needs something that's a little more intensive than outpatient therapy. He may need something like a waiver program, or someone had mentioned SPOA. And by the way, with the waiver programs, family support, so a family peer advocate is one of the services, as well as if you find that you would like a family advocate, there are family resource centers throughout New York that offer free family support. And so they can be amazing advocates for individuals who are experiencing difficulty, like in the child welfare system and so forth.
Great. Well, another question was, is IPT for adults as well?
Yes.
Yes.
It was primarily for adults, but they have broadened it to use it with adolescents.
Great. And then this is our final question. How can we get adolescents to engage in therapy and social activities when they are resisting services?
Yeah, I wish there was some magic answer for that. You know, initially, if you if you are seeing that individual consistently, hopefully, and over time, if they're willing to do the work or willing to sit there, that can sometimes, over time, as they gain trust and comfort in the relationship. But I don't know of any way in which if someone is absolutely refusing to do the work or sit there that you can get someone involved, unfortunately.
Well, you can assess some of the barriers.
Yeah, I mean, are the barriers about, you know, just not wanting to be there or not accepting that they have a mental health problem, or, you know, addressing it through that? And, you know, I feel that normalizing is really helpful for most people to say, you know what, I understand you don't want to be here, you don't see a need to be here, and then opening up the communication that way. But I can't emphasize strongly enough the power of the therapeutic relationship, and that you can start joining with that client even over their resistance, and hopefully through time they may begin to trust and see it as a place where, you know, they want to be.
Great. I think that that is all we have for today, Dr. Acri. I just wanted to take people through, we did put your contact information. If anybody has any questions or concerns, you can reach out to myself, kara.dean@nyu.edu, and then we also have Dr. Acri's information. If you could just go to the next slide.
Sure.
We can, I just wanted to, since we only have about 2 minutes left, these are the references, and then there are a bit of some resources that we put up, IPT for Adolescents and the IPT Institute, and then I just wanted to show you some of our upcoming events. And so, again, if you have any other questions or concerns about today's webinar, please feel free to reach out to me. I think you all are doing amazing work, and we really appreciate you participating today. Some upcoming events with CTAC, we have Effectively Employing and Supervising Youth Peer Advocates with Bianca, Brianna, and Azaria, which is Thursday, June 14th, tomorrow at 1 o'clock. On next Tuesday, we have Motivational Interviewing, Clinical Updates with Substance Abuse Treatment with Dr. Tara DeWitt. And then on Wednesday, June 27th, we have Addressing the Mental Health Needs of Children with Incarcerated Parents with Dr. Anna Morgan-Mullane. And we have many other offerings at ctacny.org. We do have, I just want to reference this piece in regards to not wanting to participate in services. We do have quite a few webinars in the past on engagement in services that some of you may be interested in checking out, that you could incorporate some of those ideas around some of these IPT strategies to think about treating depression in your clients. So I hope that this has been a worthwhile way to spend your lunch hour, and we really appreciate you being here with us, and we hope that you have a wonderful day. Dr. Acri, do you have anything else to say?
No, thank you for having me.
Okay. Take care, everyone. Have a great day. Bye-bye.